About 15% of reproductive-aged women have a disability. However, the needs of women with disabilities are seldom considered in the creation of reproductive healthcare services, such as prenatal and postpartum care. Our objective was to generate data that would inform the development of accessible and inclusive obstetrical care. We undertook a series of population-based studies at ICES using a cohort of about 200,000 women with physical, sensory, and developmental disabilities, and 1.6 million women without disabilities, all with an obstetrical delivery between 2003 and 2019. First, we looked at pregnancy rates. We showed that pregnancy rates in women with disabilities have increased over time, from about 8% of pregnancies in Ontario in 2003 to now 13% of all pregnancies in the province. This analysis was important because it represented one of the first whole population pictures of the frequency of pregnancy in women with disabilities, with 1 in every 8 pregnancies in Ontario being to women with a disability. Our data showed just how important it is to consider accessibility and inclusion when designing and delivering obstetrical services. Next, we looked at access to prenatal care. We found that most women with disabilities received prenatal care at about the same time and frequency as women without disabilities. However, there were important disparities, with women with developmental disabilities being more likely than their peers to receive prenatal care late and to get fewer than the recommended number of prenatal care visits. This finding shows that there are important gaps in terms of how prenatal care is being delivered for women with developmental disabilities in particular, and that more could be done to engage them in care early and to create a supportive environment that facilitates sustained access. And third, we looked at pregnancy outcomes. We looked at a number of different indicators of maternal and neonatal health. We found that most women with disabilities have healthy pregnancies and healthy babies. However, there were some important disparities that show that women with disabilities could benefit from access to high-quality perinatal care. First, we found that women with disabilities were more likely than those without disabilities to experience rare but serious complications like hemorrhage, sepsis, and maternal death in pregnancy or within the first year postpartum. We also found women with disabilities were more likely to have emergency department visits and hospital admissions for obstetrical, other medical, and psychiatric reasons across the perinatal period. We found that while neonatal complications were rare overall, some complications like preterm birth were more common in babies of women with disabilities than those of women without disabilities. And finally, we found that women with disabilities were more likely to experience other disparities in the perinatal period, like perinatal mental illness, experiences of interpersonal violence, and barriers accessing breastfeeding-related supports. These findings are all health outcomes that high-quality prenatal care aims to prevent. So, the disparities that we observed show that more work needs to be done to support women with disabilities as they are planning a pregnancy, during pregnancy, and after delivery. We are also doing qualitative research outside of ICS that shows that there are numerous barriers to high-quality prenatal care, as well as postpartum care for people with disabilities, including physically inaccessible care environments, barriers to communication, lack of healthcare provider knowledge about disability, and negative provider attitudes toward disability and sexuality. So here are a few points to consider. Healthcare administrators need to assess the accessibility of their services when creating policies and programs. This includes the physical accessibility of healthcare spaces, processes for ensuring communication and other accommodation needs are met, and flexible delivery options such as home visits or longer or more frequent visits to make healthcare more accessible. There also needs to be greater attention to the training and education of healthcare providers so that they can deliver disability-competent care. This means including disability modules in medical student and resident training, as well as continuing medical education resources, with attention to identifying and addressing inherent biases about disability and sexuality. Finally, health data systems need to be set up in a way that enables better investigation of health equity-related issues. Our research provides an important first step using the data currently available from health records. However, information on self-reported disability, as well as other important indicators of equity related to race and ethnicity, gender, and other factors, are needed to truly create accessible and inclusive obstetrical care. And finally, all of this work needs to be done in partnership with communities.